Hi, everyone. This is Joni McGarry. Thank you so much for tuning in. I think you'll agree that medicine and the practice of medicine has changed quite a bit in the last 5 years, 10 years, certainly 20 years. And our guest today, Dr. Allon Friedman, has something to say about these things. He's a professor of medicine at the Indiana University Medical School, and he's also a medical researcher. His area of expertise is kidney disease, and he is particularly interested on the impact of obesity in that disease state. He has written some articles for Brownstone Institute, and that is where I became familiar with his work. And so I invited him to talk to me today about what he has observed over the years in the change in the medical practice area, and also what he is observing at the medical school level in terms of the quality of education and the quality of the doctors that schools are now producing. He has a lot to say about the unintended consequences of DEI as it's been incorporated into medical education. And I really thought that conversation was quite interesting. So he's going to share his thoughts with us on that. I've also asked him to talk to me a little bit about his use and his thoughts on GLP-1s in the treatment of obesity and in the treatment of different disease states. And what he had to say about those drugs was very edifying to me. And I'm so glad I asked him to talk to me about it. I think you'll learn something and enjoy the conversation. And I also would just want to say, I think the world needs more people like Dr. Friedman, people who see what's happening and people who are not afraid to speak up, even if the opinion doesn't seem to go along with the groupthink at the time. We had a lively and delightful conversation, and I'm so pleased to share it with you. So thanks so much for tuning in, and let's get to it. Hi, Dr. Friedman. Welcome to the show. Thank you so much for joining me here.
Thank you. It's a real pleasure and an
Oh,
honor to be here this evening.
well, I'm delighted you're going to spend the time. Would you please tell us a little bit about yourself, what your experience in medicine has been? I've already told the listeners in my intro that you're a professor of medicine at Indiana University Medical School, but fill us in on a little bit more.
Sure. So I went to medical school at McGill University in Montreal, Canada. That's partly where my family's from. The educational experience there, we can get into it a little bit, but it was a little bit different, I think, than American medical schools. And then I came to Boston where I did my internal medicine training and then additional formal training in nephrology, which is kidney disease. And after that, nutrition. And at the end of my training, I was thinking, well, what should I do next? What's my next step? And an opportunity had come up at Indiana University in Indianapolis with the School of Medicine, which I thought was attractive. So I moved here. It was my first foray into the Midwest. We've
It
been
is
here
quite
ever
a shock
since.
at first, yes.
We've been here. No, it was lovely, and it was very different than the New England or Canada or Texas where I'd been before that. So yeah, it's been a lovely experience. And so I've been at the medical school about a little over 20 years. Most of my time now is spent taking care of patients with kidney disease in a variety of ways. And I also do, though, some research, writing, sort of scientific thinking, which we can talk about if you'd like.
I
But
would.
yeah, yeah,
Well, what put you on my radar were the articles that you wrote for the Brownstone Institute, specifically 11 Steps to Revitalize Medicine. And then the other one that I thought was very compelling was I want to get this right, Poison Embedded in the Education of Doctors. And they sort of dovetailed together because one of the core things is just the change in medical education. And it seems like it might be sort of initiated by the push for DEI across educational platforms. And so I was wondering if you could just take me through some of the thoughts you had in those, especially in the educational system. What is happening that you see that might jeopardize patient care because the education of the people now in medicine is different than what it used to be, perhaps less rigorous or differently focused.
sure. By the way, I did not make up that title, the
I
poison.
wondered, okay.
It may it may have been my thought bubble, but I did not. I did no, no, that was the editor who made that up. And you did
Okay.
mention, by the way, another article I had written earlier for Brownstone, which had to do with vaccines, which is another topic we can talk about, particularly the COVID vaccinations. That's what
Yes.
it's about. So let's talk a little bit about DEI because that was the focus of my most recent essay. And this has been an issue that's troubled me for some time now. I would say it really came to my attention, this process in this manifestation of DEI in the medical system, probably a little more than 10 plus years ago. And just for your listeners, I'll give you a brief summary of what I think, how I define DEI. So really, this is a philosophy, a worldview that uh, was first developed in about 100 years ago in Frankfurt, Germany. There was a school there called the Frankfurt School. And these were Marxists. They developed this critical theory, this idea of a critical theory, which basically looked at the world through a lens of power dynamics. And excuse me, these individuals actually emigrated to the United States right before World War II and sort of lay the seeds of their ideas in American academia primarily. And these seeds took a few decades to grow into something substantial. And what has sort of one of the things it sort of developed into is critical race theory, which sees the world through the lens of power dynamics involving race and other different groups. So the the concern I have is multi-level, I think.
Mhm.
The first is how how does DEI, and by the way, it's interesting, DEI has lovely phrasing, right? Diversity, equity, inclusion. But it's like what forgive me, what it's like what Voltaire said about the Holy Roman Empire. It was neither holy nor Roman nor an empire. And that's what I think we're dealing with Orwellian terms here. And it's not that everyone involved in this is necessarily malevolent. I'm not saying that, but some
Mhm.
people may not really understand at all what it is, but it is very, very misleading.
Right, because somebody might think, well, it just means that we want to have a really balanced incoming class of people into a school in terms of race and income and different backgrounds. I mean, that's what a lot of people take it to be. But what you're
Absolutely.
saying is that it's very, very different than that, or perhaps just much more than that.
It's very different. And I think it's a kind of a shock to the system when you've, uh, when you have another philosophy about how we should interact
Mhm.
with individuals and with groups in society. And I think from an individual's level, the problem with it is that it judges people uh, by their group, um, or color or race or so on. It sort of groups individuals into these categories rather than assessing the individual at face value,
Mhm.
or his or her own characteristics and achievements and goals and so on. Um, and this is an enormous problem. I mean, certainly, at least from the standpoint of medical education, it is, in my opinion, really poisoned the medical education in this country. And by the way, this is, as you know very well, and I'm sure your listeners are aware of, DEI. This is not something unique to medicine. It basically
Right.
it basically became established in academia, and medical education is part of academia. You don't have private groups training students. It's all university based. So
Mhm.
what has sort of attacked um, and really taken over at universities has done the same thing in medical schools. So the first issue is how DEI influences the makeup of medical school classes and success in the medical world. So from the standpoint of choosing who your next doctor's going to be, who's choosing who future doctors are going to be, I think if I asked anyone point blank, I think they would say, "Well, I want the," they would probably agree that they would want the doctors to be the most outstanding individuals that could be found from an academic standpoint and from other standpoints as well, obviously.
Mhm.
But the first criteria has to be academic excellence and achievement and skill in this area, because medicine it does require a lot of intellectual power to
Mhm.
be a good physician.
Yes.
And what we've seen is that DEI has really damaged this. That it selects certain groups over others. or I should say, select certain individuals over others simply based on their group affiliation. And this has had, I mean, you can actually see from data from the American Association of Medical Colleges what the likelihood of individuals being admitted to medical schools are simply based b- by their MCAT score, the medical admissions test
Mhm.
score, as well as their GPA, their grade point average, uh, by 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 category of race or sex, and you can see that I mean, basically black and brown individuals who are black or brown, as they're sort of defined,
Mhm.
have much lower MCATs and GPAs than do whites, and especially Asians, who have the highest categories. And I think this has really watered down quality overall. We can see also that this doesn't just involve the admissions of individuals, but involves how medical school students are handled throughout the entire medical education process. And we can see there are actual data, or actual, at least anecdotal data, that demonstrate that students are just not, that they have a lot of troubles with students passing scores in a number of schools, like for example, UCLA in particular, as it was a nightmare, where the DEI ideology took over entirely the medical school. And now you have very large proportions of the classes failing clinical rotation tests. So at the end of each rotation, whether they'll take a test, and it was scandalous. It was in the news maybe in the last year, and there's an organization, Do No Harm Physicians, that really is anti DEI.
Mhm.
They brought this to the attention of the national audience, and these type of things are really, really troublesome. So I think from the standpoint of excellence, it really has harmed, in my opinion, has sort of
Mhm.
harmed overall the rigor and caliber of students that were accepted. And by the way,
Because
I have nothing.
what
Yes,
you're saying is that the academic standards have been lowered for certain groups in order
yes,
to
no question
have
about that.
have a more, diverse, and I mean diverse and immutable characteristics, not in thought, but in order like in a more visually diverse or, background diverse class.
That's right, and I think that it's interesting because when I think of diversity in medical school, my number one type of diversity I would want would be intellectual diversity.
Same across
Okay,
all
that's
education. Yes.
yes, in any area in academia or in the university, we want intellectual diversity, but we want to maintain a level of excellence.
Mhm.
And that I think has been really harmed. It's interesting, by the way, that the the even when universities try to select, let's say, a certain proportion of students who are black, let's say, it's very difficult for them to find that. And we know from very rigorous studies done in the United States that there are simply not enough black students who achieve at the level of academic excellence that is required, in my opinion, to enter medical school. It's just not there. So they take, for example, they fill their black quota system with individuals from Africa or the West Indies. It's not even American blacks that are uh,
What you're
that
saying is
are
that they're just going for skin color, they're not even trying to make the class more representative of the American
of
population,
the American population. That's
right?
right. That's right. Right. It's
They're
not.
just
It's
checking a box for immutable characteristics.
absolutely. And so that's the first issue, I think. The other issue is that from an ethical and moral standpoint, I mean, it's very troubling to, especially as an American, it's very troubling to be in a system where people are judged simply on the basis of their color or race or sex, right?
Right.
It's very troubling. And again, from an ethical standpoint, the DEI does establish this sort of pyramid where there's
Mhm.
certain groups at the top that achieve that really accrue the
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 f
benefits, and the stratum on the as you go down the pyramid, there are less and less benefits that are provided to this group. On the bottom, you're going to have whites, males, I
Mhm.
think Jews, religious Christians. That's where you are on the bottom stratum. That's just the
Mhm.
reality. Um, and
And
yes.
And, how are you seeing do you see this in your, teaching right now? As you teach in medical schools, as this has taken hold, have you seen a change in your, classes as a result of this? Is your experience different?
Well, I teach primarily on the wards. It's not I'm not I mean, I do a very little teaching in the actual
I
classroom.
see,
It's
okay.
mostly in the clinical realm, but I mean, there are all types of stories, both locally and nationally, about ideology being injected into the
Mhm.
medical education system. This is part of it. I'm gonna tell you a story that, may be shocking to you, because another aspect of DEI is really it's a very aggressive and, um, sort of domineering ideology. And if you don't agree with that, I mean, you'll be shunted aside, ostracized. You could lose your job, at least in a previous era, perhaps not
Mhm.
now because of the new
Right.
administration. But here's a very short story for your listeners. I wrote a s I w This is about 3.5 years ago. I wrote a letter into my local neighborhood newspaper. It was a 150-word letter that was very polite, where I described how I thought, and I gave a number of reasons for it, succinct reasons, why it was a bad idea for my local school system to hire a DEI coordinator, the first DEI coordinator. Well,
You mean your local,
my
K through
local public school
12?
system, my
K
local
through
public school
12,
system.
wow,
Yeah.
okay.
And that was that. I thought, I'd never hear anything about it. Well, the day after it was
Well,
published.
sorry, you can
Yes, well, you're
I
getting
live
you're
I live in Bloomington, I think you'd hear a lot
uh,
about it. Yeah.
the day after it was published, I actually was tipped off by someone who was part of an internet group saying, "I'm really sorry about this, but I'm part of this group, and they're gonna try to come after you and get you fired." So, again, I was at the medical school. At this point, I did have tenure. There was a group, a number of people, primarily females that I could tell, I mean, nearly exclusively females, who called the medical school, called the dean, were outraged that I should. And again, remember, this was the heart of the Biden period, during part of the tail end of COVID too, which didn't help.
Right.
And,
But you were
um,
expressing your opinion on an issue that affected your neighborhood in your neighborhood paper that had nothing to do with your position as a medical doctor.
I wrote it as a private citizen.
That's right, okay.
And basically, how do I even summarize it all? The back and forth went on for a couple of months. I found out that I was being called a racist
Of
on the
course.
internet via not only students, but faculty and even
Oh,
associate deans in the
oh
medical school.
gosh.
This is at IU. Um, there was even a hint of anti-Semitism between I can't tell you for certain, but I'm fairly certain that was the underlying message there between a faculty member and a student. Um, and In the end, nothing happened to me, but I did have to. It felt uncomfortable enough that I hired a lawyer for this period of time,
Mhm,
and it was recommended to me that I probably don't pursue any legal recourse, because it would be hard to prove damage sort of in the
mhm,
public sphere,
mhm.
and you would be bogged down by this. It could probably take years. That was the
Right.
atmosphere that everyone sort of, I think, kind of, at least many of us sort of got a taste of.
Sure.
But if you're in universities, it was really, really bad. And the reality is that I don't think that really things are any better in terms of the stranglehold that DEI has on these institutions. Things are quiet now,
Mhm,
and universities are trying to, and leaders for the most part are trying to suppress it all. But if a new administration should come into power, then I think you'll see a resurgence of all of
mhm,
this again.
mhm,
So it's not like it's gone anywhere. Another, let's see. So so that's sort of giving you a sense, I think, from a moral and ethical standpoint,
mhm.
how ugly it is, how ugly the arena is.
You
Uh,
mentioned, in
yeah,
your article, when you talked about DEI, more like that somehow that morphed into people not wanting to wear white coats.
yeah. So
And I found that example very interesting because I never thought of the symbolism of that. Can you tell us a little bit more about that and what you make of it?
sure. Well, this actually it's the jives well with it with the next level of how DEI adversely affects the medical system, which is via through patient care. And before I get to the issue of white coats, let me just add a brief story about. Um, well, actually, let me start with the white coat story. So, yes, I was rounding with I learned and I grew up with wearing white coats as not as simply a symbol of the sort of the healer, but it's something that actually helps patients and the patients want. They want to feel like it really is it really reflects a very powerful symbolism, I think,
Hmm.
for most patients. There have actually been studies that show that patients prefer that their physicians wear white coats. So I was speaking with some of my trainees, medical students, residents, and so on, and fellows, and it turns out that this was sort of discouraged because it may reflect sort of a power dynamic and imbalance, which again is jives perfectly with DEI.
Hmm.
Now, I'm not sure, there may be other things going on here, and maybe it's just sort of out of fashion to wear a white coat. But to me, it was a perfect example of how DEI, the ideology claims to profess a real interest in support of patients, but its influence actually does the exact opposite, harms patient physician relationships and patient care. And by the way, I've seen this in the hospital. I've seen how physicians who are so obsessed with politics and DEI basically fail to do their basic job of taking care of the patient. It's actually shocking to me. I
Hmm.
can't say I've had many instances of this, but I have seen a few.
Can you give me an
And
example of what that would look like?
okay,
I because I can sure imagine it, but I don't wanna put
without
words in your
using
mouth.
specifics, sure. Well, I'll give you two examples. One is uh, a patient I took care of who had an acute medical issue. Um, went to the emergency room. The specialist there saw them, should have referred the patient to me immediately, but there was a delay of several months. And when I finally saw the patient, I emailed these physicians who were involved with the care, and I said, "Listen, just as a teaching, actually, I started with the resident, just as a teaching point, I would recommend if you ever see a patient like this to refer them to my specialty or another specialty immediately for the patient's own sake." And I got huge pushback from the resident. Uh, the attending then was added on, and after give and take, they were, I would say, not very respectful to me until they found out that I was a staff, faculty
Mhm,
myself, and then they were much more polite.
mhm.
But they didn't really seem to get they were so enmeshed and wrapped up in politics. I thought, "This is insane. This would have never happened years ago." People would have just the way I was trained, and everyone that I know was trained was focus on the patient. The politics was irrelevant, which
When you
brings
say,
me to
like, the politics of the institution, not necessarily the
no,
politics
the politics of politics, women's
ah,
rights,
I
women's
see.
this,
Okay.
that. Yeah. So basically, they overlooked the basic this, and I couldn't even politely suggest to them doing something a little bit differently. And at the end, we're so sorry, but they never really got the
The
thrust of it.
point.
Another example, by the way, is personal experience I had in a hospital with a trainee who, in let's just say, not too long ago, would have had a tire and presentation that would have been utterly unacceptable,
Unacceptable.
unacceptable, and everyone would have known that. These days, almost everything goes, including hairstyles and so on, paraphernalia that I think turns off a lot of patients, certainly turns me off,
Yeah, you talked
and
about it as being, like, this narcissistic edge to the
abs
students now, like, "I gotta be me, and it's all about me in the clinical setting."
yes, that's right, and this was actually not a medical student, but a resident,
Mhm.
and there was also this trainee also wore a lanyard, which was highly political. Now,
Yeah,
I was at the point I was sick. I mean, thank God I wasn't that sick, and I had all my faculties, and it resolved quickly. But I was in an emergency. Can you imagine? I was a physician there, and this person had no trouble presenting themselves to me like that. And I thought to myself, my God, if I was at least 50% of the population, I would be intimidated, cowed, disturbed, all this together. This is not the way we treat patients. We treat patients, the patient comes first, not the individual's own, as you said, not the individual's own feelings or beliefs. That's irrelevant when you're in the medical realm. And by the way, the reason why trainees do this is because they're not only supported but encouraged to do this
Hmm.
by educators. That's who's mostly at fault. If the educators would tell these trainees, you need to leave all politics, you need to have attire and presentation that is respectful and appropriate for everyone, so it's
And
not
very
offensive or
neutral. Yes.
troubling.
Yes.
But this is the world we're living in now in medicine. So, anyway, so that's just another example of how troubling it all is from my standpoint.
Well, no, I would agree because I don't like in schools in general or any transaction you have professionally. I'm always put off by even a small business leading with their politics. Totally, I think people should be who they are and purchase and go according to their beliefs. But especially a medical setting or an educational setting, you're really relying on the person to person interaction. You don't want to go into an ER and think this person would hate me if they knew my views, or you have to lead with that kind of. I think it's very aggressive, and
It's
it's
very
very presumptuous too. It's extremely presumptuous.
it's aggressive, it's presumptuous, and it's also very disrespectful to the patient.
Yeah.
Very disrespectful. This is, and again, this troubles me. I'm not saying that most trainees are like that, and but there are some, and sometimes it's quite aggressive,
Hmm.
and you feel like in this environment, they almost know that they're never gonna be punished.
Right.
Nothing will ever happen to them. In fact, if you complain, you're the one that's gonna more likely to get in trouble.
Right.
And then I'm pretty certain that this was in my, institution where I work, but I'm pretty certain that things are worse. I mean, as bad, if not worse, in many other institutions around the country, in places that are much more supportive of this type of behavior.
Hmm. Hmm.
And
I
by the way, let me just add one last thing.
Sure.
I actually, I actually contacted the chief educators in my institution at this time and complained about this as a patient. And their answer basically is that we're okay with it. We're okay with it.
Now, I don't think they would have been okay with it had the person been wearing a very political lanyard expressing the other side. Like if somebody came in, and I'm not saying it doesn't, I mean, I don't find the whole right thing all that useful anyway. But if someone came in wearing a MAGA hat and they were your ER physician, or, that wouldn't be tolerated by the educational institution. It's the lack of consistency that bothers me as much as anything else.
Jody, your example is a beautiful one because that's exactly what I posed to them. I said, I responded to them and said, well, if this person had a lanyard that said MAGA, would
Yeah,
that have been tolerated? And I received no response, which basically is an answer.
sure it
An
is.
answer.
Yeah. Um,
So these are real problems for patients, I think. And but I'm sorry, I don't mean to cut you off,
no, it's fine.
but
You're
my
my
point
guest.
was just what I was just going to say was that I truly believe in my heart that if legislators knew how this is going to adversely affect the care of them and their families and their communities, they would just be in shock and probably, who knows what they would do. But I
Right.
think somehow and some things have been done obviously to try to crack down on it, but it's so difficult. It's so difficult to crack down on.
Well, it's difficult to even discuss it because, I mean, you wrote a letter just probably talking about the unanticipated consequences of hiring a DEI officer for a school system, and you get smeared and you get threatened with firing. And so there's a whole barrier to even bringing these things up. I recently heard a story that in a medical class, somebody wanted to talk about obesity, and somebody raised their hand and basically shut down the conversation because it was fat shaming. And and that leads me into something else you wrote about race in the context of is it called history and physical, which is
Yep.
it's called the
Mm.
history and physical. And tell us what that is and what is usually upfront with something like that in order to be very clear on who the patient is and what they're about and what, especially with the race component
Sure.
of that and how that
Sure.
can lead to, poorer medical care.
Sure. Well, the history and physical is basically the documentation. It's a scripted evaluation of the patient, written evaluation of the patient that trainees learn from from the first time in medical school when they start dealing with patients, and even before that. And the purpose of this is to assimilate all this information, the history of the patient, what happened, the history of the disease process, what happened, what's going on, add to it the physical examination, then add the laboratory data. And it's sort of like a funnel. You're funneling down all this information. And at the end, you get these few drops of gold, basically the thoughts of the summary in a very succinct way of what the physician thinks going on, what are the possibilities, and what are the next steps.
Hmm.
It's a real art form to do this. And it's been made a little more difficult these days because of electronic medical records, but
I want to talk about that too, but go on.
another nightmare in the system. So, so what when I was taught, and I will say, I was taught at McGill University, which it's a well-known
Hmm.
medical school in Canada. It has sort of a British style system and background, which was totally no nonsense. Even in those days, I'm sure it was much more nonsense than American schools at that time. But I think even in American schools, this wasn't controversial at all. The first sentence is an ID, an identification of the patient. And by the
Hmm.
way, the part of the utility of this history and physical is that it allows anyone to read it to get a sense of what the physician's thinking and to follow that.
Hmm.
So the first line is whether it's in presentation verbally to a team or in written report is you start with the patient is a X-year-old male or female, white, black, Asian, some ethnicity or race who presents with belly pain, let's say.
Okay.
Okay. So what's happened in the last number of years, and I don't know exactly when it started, was race has basically been dropped out. And it's fascinating to me. I think it really started probably around 2020 or so, especially when race became so touchy that this was like a fever that swept through the medical
The
profession.
mania.
It is a mania and it remains a mania. Where now, students they're told to sort of, I think, to avoid this or put it in another section when it's such an obvious and important thing. It's not because physicians are racist, because it actually adds very useful clinical information. Like,
Because
for
are there
example,
not conditions or background situations that are very race connected that have much to do with a physical diagnosis or a disease outcome? I mean, we're different.
we're different. And, race is basically reflects to a large extent, um, genetic background. And it's no surprise to anyone listening to this that many diseases are genetic, they're inherited.
Mhm.
And so I can give you an example. If I see a patient with kidney disease, a very common problem in the Black population, that is people with Black skin who have African ancestry, is a mutation called ApoL1. And if they have two of these mutations, they have a much higher risk of developing kidney disease. And if they have other types of disease, of developing kidney failure. So leaving that out is problematic. Okay, it's not because physicians are racist. We actually want to help our patients, and this is a clue.
Right.
This is a clue to help hone down the likely diagnoses, so you can get to the real answer and treat the patient. Now, I'm not. I still think my guess is that most physicians probably still use this, but taking it out of the taking it out of the history and physical is problematic for me because it suggests something else. It suggests the touchiness of a race that shouldn't be there when you come to a physician. And by the way, um, one of my sons said to me, "This is a very strange thing. It's as if the people who are training physicians don't trust them. They don't trust them to consider the idea of race in a mature way that doesn't involve, I don't know, all this other politics and stuff."
Right, like, as if you're presented with a patient who is not of a race that you are or something else, that you're going to somehow treat them differently as a patient if you know what their race is, or
Yes.
think of them differently. There's also the issue of the transgender stuff, and, I know a radiologist very well who sometimes, in his practice would see an image and there would be a name on the case, which would be gender, like, like a female gender or male gendered name, but there was no indication in the medical record that this person was not born that gender. So at first, when they're presented with the image, they're a little confused at what's going on. So it takes more time to to know what you're looking at, because you aren't allowed to know the sex of the person as they were born, because somehow that's offensive to the person giving the medical information during the intake. It's just cuckoo to me. Like,
It's madness, and it's harmful to the patient. That's the
yeah.
problem ultimately we get when we get down to DEI and all the other politicization. It's harmful to patient care,
Mhm.
and it becomes bizarre almost. And then, you begin to question your sanity. You're working in I mean, it's for example, it's like in the British healthcare system, National Health Service, where they're telling people that, you know, individuals who are male by genetics and born as males need to have a pelvic exam because they had made a little pouch for a vagina or something like that.
Right.
And you think to yourself, what in God's name are you talking about?
Right. Like,
Does it have a cervix, or what are you talking about? But this is the madness that's going on, in
everywhere.
much of the Western world, by the way.
Do you
Most of
see
the
an
Western.
Do you see any hope for change? And then there are a number of other questions I want to ask you, but like, I know in the Indiana educational system, the higher educational system, there are some changes afoot because of some new laws that are passed that have changed out the nature of our board of directors for Indiana University. And I know they have some influence over who is the dean of the medical school and things like that. Is there any? Do you think there'll be any shift toward a less DEI laden educational system on the state level in Indiana because of that?
Are you asking if is there any hope at all for us? Is that the
I'm
question?
asking that, yes.
Yes, yes. I would say that, it really kind of depends. I think that universities right now, my impression is from my reading and just from, observations, the universities are really afraid of from a financial standpoint. They don't wanna have to pay $100 million like Harvard did or whatever they
Sure.
see they paid, or Northwestern just paid 75 million, which is probably
Right.
not enough, frankly, but they're afraid. So I see things that have happened. They've cracked down on certain things. The
Mhm.
medical school is definitely quieter,
Mhm.
and as I suspect probably in most medical schools it's quieter. But ultimately, I think so many of the people that are running it really have the same feelings and ideologies that they did before all this. And like I
Mhm.
said, I mean, once the pressure valve is sort of turned off, wouldn't be surprised if this all returns.
Sure. And you
That's my
also
problem.
and you mentioned that this is also happening or being pushed top down from the accreditation agencies. You mentioned that in your article, that how medical schools get accredited. Is there a DEI aspect of that as well?
Yes, well, I was say that DEI has basically infiltrated every corner of the medical institution, from national research institutions like the NIH,
Mhm.
National Science Foundation, to mainstream top journals, to societies, medical societies, to down to medical schools. It's everywhere. And the accrediting agencies are part of this
Mhm.
because for some time they've really forced universities to adhere to DEI criteria, which is a real problem, obviously, because someone had given me once an example because it was actually a dean of a school that pushed back. It was Tulane, if I remember correctly. This was a number of years ago. And they said, no, we're not doing this. And the problem is that if you don't adhere to their criteria, your school is at risk of losing accreditation. So
Mhm.
you may win the battle because you go to court and maybe the judge may decide for you, but that's probably 5 years down the road. And by that time, your medical school is closed.
Right.
So if this is a huge problem. Accrediting agencies are all corrupted with this stuff. It's a
Mhm.
huge problem, a terrible problem. Mhm.
Do you think is there anything good about DEI as you see it?
I guess the acronym is a short one. I don't know. I mean, no, no. This, as someone who's sort of been I hate to call myself a victim, but someone who's been targeted. No, I think it's very pernicious, it's very destructive. I don't really
Mhm.
see Nothing comes to mind. I'd
Okay.
have to think
Well,
about that
no,
a little
hey,
more
that's fair.
carefully.
That is fair. What was I going? I have a number of things I wanted to talk to you about. Okay, sponsored accreditation DI. Oh, this is probably along the same lines. Is that when you went to medical school, and at some point in the recent past, there were grades, and there were and I know when you do clinical rounds and everything else, I mean, people were on the hot seat, right? You had to perform, and there were people got to be the best and first and second and ranked and according to meritocracy. Now there's a move toward or away from grades and pass fail. Has that completely taken over?
It excuse me, for
Because
the most part, it
I don't want a doctor who just passed.
yeah,
Like, I
right.
want a
Well,
guy
I'm
who's
sorry, but
got an A.
that's the situation. Look, I will tell you, when I went to medical school, as I said, my medical school was especially, I don't know if
Rigorous.
rigorous is the right word, but, severe. I mean, you
Mhm,
basically it was a grueling first 2 years, and
mhm.
if, um, if you failed a class, you would have to take all the classes over again, even the ones that you passed. If you failed any of those, you would be kicked out. These days, I doubt that many people are kicked out at all unless you have serious problems. But grading is a real issue from my standpoint because I mean, the reason why I believe that grading is sort of passe now in so many. Now, I would say that so typically medical students do about 2 years of basic science
Right.
work, which is in the classroom. And then the last 2 years, they start working with patients. So um, I believe that all of the basic science classes are pass fail. There's a major national exam after those first 2 years, which is pass fail. I know that for the
When
last
did that start? Like, when did that happen?
fairly recently, I think I can't tell you the exact dates. I know that for the last 2 years, all I can tell you at IU that which I suspect is again just a reflection of the national trends that
Sure.
there used to be like 3 or 4 tiered grades for clinical rotations when you work with patients, and now there may be two. So it's hard to really differentiate. And then there is one test which is not pass fail, which is the end of medical school, or the maybe towards the end. But from my standpoint, I think one of the main reasons why this is occurring is because grading allows differentiation of excellence. And
Which is what
powers
you
that
want.
the powers that be don't like that.
Yeah.
Powers that be don't like that because not, you know, because there are maybe groups that will be disproportionately affected, the
Mhm.
favored groups or whatever, they'll be disproportionately, and they don't like that. So this is a
Right.
way basically this is a way to sort of obscure it all. But ultimately, it doesn't do from my opinion, doesn't really help matters. It actually makes them more complicated because I'll give you an example. So how are students going to differentiate themselves these days? Well, they do this in sort of a crazy way that never would have happened not too long ago, which is the way that they now gain entrance into the most competitive residency
Mhm.
programs is basically having to do faux research. Okay. So when you're a medical student, I mean, that's 99% of your time is studying, learning, working, training. Now the students are forced to do these publications on a variety, do some quote unquote research, which will generate these abstracts, presentations, maybe even papers that are published. But all it does, I think, is it just diminishes the rigor and quality of the science. And now you're just looking at numbers. Oh, you need X number of papers to be interviewed for let's say dermatology program, or Y number of papers to be interviewed at a plastic surgery program, the most competitive programs, for example, some of the most competitive programs. So it's now perverted the whole system instead of the students being able to focus entirely on what they're there for. Now they have to spend their time doing these other extracurriculars which don't necessarily help don't advance science. I don't really think that. I'm not sure how much they learn from it. It's just exercise in madness. So this is what happens when you remove markers of excellence to the system, because
Huh.
ultimately there has to be a way of differentiating people,
And
and
so
that's what it
they
was.
well, they're differentiating them with what seems to be like make work that takes
Yeah,
you out of that.
that's right.
that
Soft, it's like soft stuff.
yeah. Um, so let's just pivot over a little bit. So we've got this problem in medical education that's, I don't know, you're not making me feel terribly optimistic about. And then also there's a problem with the way medicine is practiced nowadays. I mean, it wasn't so long ago that doctors were in individual practices. They owned their own practice. They could decide how long they spent with patients, how they would treat patients, whether they were going to require their patients to have a certain intervention in order to stay a patient, what they were going to recommend to those individuals. And I know in Bloomington and everywhere around the country, most individual practices have been subsumed by the hospital systems. Small hospitals have been purchased, and everyone's now working for the corporation. And what is your take on what that's done to patient care, to
Mm,
physician well-being, the
autonomy
whole
and
thing?
sure, sure.
Yeah.
Um, uh, Look, I mean, in a nutshell, I think it's very, very bad, and I'll explain why. You've described the move from majority physicians in the United States being private practitioners, really fairly recently, to the majority being
Employed.
salaried,
Yeah.
employed by large hospital systems. And the reason for this is because the government has wanted it to be this way. Um, through even prior to Obamacare, but especially during Obamacare and afterwards, there are incentives and disincentives which make it more likely that a physician is going to be able to survive and make a living if he is being salaried and employed versus whether he's going to be on his own. And I don't understand the rationale for that, other than perhaps there's so much money in
Yeah, to me, it
lobbying,
just seems like there's a profit rationale.
yeah,
Um,
in lobbying in Washington D.C. I would guess would be a very large issue. But the reason why I think this is so detrimental to patient care is number one. I mean, what happens when you have oligopolies or monopolies, which is basically what's happening? You reduce competition,
mhm.
you reduce quality, you reduce innovation, you increase costs. This is all happened. And I think that this is a major, major problem that needs to be addressed. The other thing is for physicians working when they become salaried, they lose autonomy. They lose,
Mhm.
frankly, they lose freedom of speech.
Mhm.
Um, they're required to be. By the way, my exposure to these large hospital systems that they're generally not well run. They're not innovative. They're flat-footed. They're huge bureaucracies and administrations that basically make life torture for all medical medical faculty and nurses and ancillary care. It's a horror show. It's a horror show, and it's just how does one? I mean, it's like every other large corporation. That's just what
Yeah.
it is. So I personally hope and pray that at some point, hopefully some point soon, that people in Washington will begin to see the light and will begin to stop putting their finger on the scales, allow for free competition,
Mhm.
allow physicians to work for themselves, allow there to be incentives for that, or at least remove the disincentives
Mhm.
and level the playing field. I think it'll be a much better state overall for patient care because I think now things are you're not really seeing that, in my opinion.
No, I don't know anybody
No
who's happy.
innovation.
Yeah, and I don't know anyone who's really happy with the system. We just had a new hospital built here, I don't know, as you probably know, maybe 5 years ago, whatever, and they built the stuff it's too small. People it's and so people complain all the time, and if you go, you get 15 minutes with a doctor, and you can't even call your doctor's office, you have to schedule through central scheduling, they don't know you. I mean, we're all there.
Let's just say it's a large bureaucracy. That's what it
Yes,
is.
it is, it really is.
Poorly run bureaucracy.
Yes. Would you mind commenting on what you observed? I know you wrote the article about the COVID vaccine mandates and why they
Mm,
were divisive and expensive and ultimately not very useful. And that's a subject near and dear to my heart because what I did during right about the booster time is I co founded No College Mandates to fight
mm,
the mandates at the college level. And um, what I was really disappointed in, and as we all know, is that the people who were academics and doctors, they didn't seem to question. whether this was a good idea to mandate a product that was poorly studied, that, it was leaky, did not, it wasn't a sterilizing product, it didn't prevent transmission, yet they were forcing people to get it. Um, what was it like for you in that situation? Did you notice any dissent at all among the ranks?
Mm. It was extremely depressing. It's a very depressing period to think about. And I know it wasn't just me. There were very few people, if any, that were speaking out. I really tried very hard to interact with the powers that be at my institution.
Mhm.
And again, I don't want to single out my institution. It was the same. This is
Everywhere,
not
yeah.
everywhere. It was just, there was, it was frightening to me because I grew up thinking about physicians as independent, critical thinkers.
Mhm,
That's always the example that I used. I'd seen physicians think that way. And by the way, the people that I work with, I mean, many of them are brilliant people.
mhm,
They're really brilliant people. But there was no dissent. There was no second guessing. There was no critical evaluation. There was even not very careful assessment of the medical literature. People just took it at face value. And, so much of it was politicized. That must have played a big role. People just went along with the politics of their group,
mhm.
which are, you know, and so that I think is really what happened. It's so depressing for me to think about. It really, I know I have friends who are physicians too, and a few of them really felt the same way. And it's devastating. It's
Yeah.
devastating when you see your profession behave like that. Uh,
Now, in the years since, and there's a lot of stuff coming out now about the harms of these products, which many of us have known all along, and they're starting to put forth the records, the VAERS records of the injuries from the COVID shots. I think I don't know if that's gonna get any traction because people just tend to dismiss sources that aren't their trusted sources as kooky, right? So, like, this administration knows nothing if you're on the other side of it, etcetera. Are you seeing anybody, in your circles say, "Huh, maybe we didn't do such a great job with that," or, "Maybe lockdowns weren't a great idea. Maybe we shouldn't have mandated these products," or is there just no, consideration of that?
That reminds me of the song. It reminds me of the name of a song, which is "The Sound of Silence." That's basically what there is. Okay, there's nothing going on here. There's nothing going on. I personally I feel that there needs to be not a truth and reconciliation committee, but a truth
Mhm.
committee with the
Yeah,
people that really made the decisions brought to light.
right.
Because unless people are exposed for I mean incalculable harm that they did, things aren't going to change the next time around. And
Yeah,
I'll tell you, during this, by the way, just as an aside, during the COVID period, I actually suggested to someone who was higher up that we institute debates on what are called grand rounds, medical grand rounds, which
yes.
are weekly rounds for the entire institution where the people give talks and so on.
Mhm.
I said I would be happy to take the con side of masking because masking has been, in my opinion, has just a disaster for patients, for the medical system. And there was initially, oh, good idea, and that nothing ever happened. I sent a few more emails, and that was that. Nothing, clearly, there was not interest, but there's no introspection at this
Hmm.
point, at least from the powers that be. I think it has to come from the federal level.
Yeah,
I
there
think
has to be
because
accountability.
there has to again, there's fear in the system. People are afraid. There's arrogance. There's real stubbornness. It's not. I mean, it's not what I expected
Yeah.
in my field. I was just not expecting that.
Well, it's interesting because even when I was shocked at the time, and I still sometimes forget, and then I'll see a picture of, like, a bunch of young women who are running a cross country meet outside in masks, and I think, "Yeah, yeah, it was really
Mm.
that bad. It was really, really that bad."
It was Orwellian. It was
Yeah.
Orwellian.
And I don't know
And
it's even worse now, though, because there's been enough time and distance, and people still can't see it, but
no.
you can only do what you can do. I have other questions I wanted to ask you too. Um, eh, along the lines of, the practice of medicine, talk a little bit about diagnosing a patient and what's being lost with technology. You talk a little bit
Oh,
about that in your article because I think it's a really important um, that how doctors aren't real diagnosticians anymore.
yeah, it's one of my favorite topics because I love the physical exam and the bedside evaluation because it establishes a connection
Mhm.
between me and another human being, my patient, obviously. And it allows me to use my skills of observation and my other skills I have
Mhm.
to
Mhm.
elicit critical information on that's necessary to treat this patient. And without that, I'd be lost. I don't know where I do. I mean, I know what I do. I'd probably order expensive tests, which may not help in ultimately in any case.
And you'd order a
But
lot of them so you won't
well,
get
and
wouldn't get
right,
sued.
I'd irradiate the patient. All my patients would be glowing basically from all the
That's
X and
right.
all the CT scans. You
Mhm.
know, I trained in a again, I trained in Canada where the bedside physical exam and the bedside evaluation was very important. It was sort of from the old British style.
Mhm.
I'm not sure if they're doing it anymore, but I loved it so much. I really focused on it. I mean, that really became a key part of my patient evaluation and still is. And I love teaching trainees about that. But what you're seeing is, you're seeing that being lost, I think. Um, it's not, I mean, it's putatively, it's important. That is like everyone requires it and the accrediting agencies require and all that. But when it comes to the day-to-day evaluation of patients, it's just underutilized.
Mhm.
I don't know whether I think it's probably multiple things. Maybe the pace of things.
Mhm.
Electronic medical records have just been a dagger in the heart of bedside evaluation, clinical evaluation.
Say a little bit more of that. What does
Oh,
that
it's this
entail?
curse. It's a curse that's basically we've been all physicians have been cursed with this electronic medical records that were initially designed to bill for billing patients, and now we're all forced to use them to document the history and physical, which I talked about, as well as any other encounters or information. And it's not just that they're cumbersome and excruciating to use, but they're very disheartening for physicians to use. Take an enormous amount of time. They're just they're just curses on the medical system, and they take so much time and effort that it detracts time from trainees learning at the bedside next to the
Mhm.
patient, and also it actually perverts the whole system because now you can have it can all be auto populated.
Mhm.
Like, it's gibberish, but it's auto-populated, which means that Medicare, CMS will pay for it, but it doesn't
Right.
really mean anything in terms of patient care. So,
But it's the
so
most important thing though is that they get paid. I mean,
oh, what else?
that's
Well, listen,
that's the
I don't I mean, we everyone should get paid for their time and effort,
I
but
agree
yes,
completely, but the way
yes,
that you
no,
guys
this
have to spend your time is insane.
it's insane,
It's
and
insane.
I do, I don't know what I would do without just to get back to finish up with the clinical
Yeah.
evaluation. It is so it's invaluable. It's invaluable, and it really establishes a rapport with patients. I mean, not being able to touch the patient or hardly touching the patient, or I just think that it's not. There's so much. Yes, there's wonderful technology now about for to diagnose and to treat, but that's still a key part of it. We're dealing with human beings. We're not dealing
Mhm.
with robots at this point. Still,
Well,
we're
you can also
That's it.
discern yeah, yeah, you can also discern a lot of information, and it's not quite as expensive as ordering a CT or an MRI. I think all of that stuff is so over ordered, but this is where we are. Um, okay, so we're a little bit depressed about medical education. We're a little bit depressed about healthcare, except there are doctors like you out there, which is great. I want to pivot a little bit because I came to learn that one of your areas of expertise is the use of GLP-1s to in obesity as it relates to kidney disease. And to me, the GLP-1 thing is kind of an interesting hot topic. It's very politicized. What do you make of all of that? How are they useful? What's your take on it?
Sure. Um, well, I mean, in a nutshell, I think it's going to revolutionize medicine. And
Oh, wait, and one more thing. You mentioned
yeah,
that you studied nutrition, which is very unusual. So I'm sure that helps you with the study of obesity and kidney disease. Okay, just wanted to say
Yes, well, you're absolutely right.
that's
Actually, the
really
reason why
unusual for an MD.
the I've always had an interest in nutrition, and my first research projects actually involved studying kidney function in people who were obese who were undergoing bariatric surgery.
I
Because
see.
at that time, this wasn't that long ago, let's say 20, a little more than 20 years ago, or about 20 years ago, it was really the only way that weight could really, you could really lose weight consistently and in
Mhm,
large amounts. Okay.
mhm.
So I've had an interest in a variety of areas of overlapping between kidney disease and nutrition, but this was definitely one of them, obesity. And lo and behold, over the last few years, we have, I mean, GLP-1s have been around for about almost 20 years,
Oh, is that
but
right?
yes, but really the most effective ones have just been around just shorter than that. Let's say, I don't know, 9 years, something like that. But they've really been, it's in an area that is exploding from the
Mhm.
standpoint of research and treatment. And as one of my friends very elegantly said, it's basically the cure for modern living. And I think he was, and I think that actually, I mean, all right, that's not ironic or, but it's actually a clever insight because so many of the problems that we have living in our society, in modern society, abundance of food, exposure to food, um, you know,
Bad food
bad, well, whatever that is, right, maybe not
or
unhealthy
unhealthy
diets,
yeah.
poor lives, poor general lives, not very low activity, and so
Mhm.
on. These GLP-1s are really remarkable. We're
How
still
can you
learning.
talk about how do they work? What are they
Yeah,
exactly?
so that's a good. So basically, they mimic a hormone that's secreted in our gut
Mhm,
when people eat. And what this hormone does is basically a couple of things. Number one, it releases insulin, so it actually can lower blood sugar levels, and also
mhm,
it suppresses appetite. So
mm.
it's sort of the body saying, it's a signal of the body saying, you know what, you've eaten, that's enough. It's now time to deal with the food, and you're not going to eat anymore. So through a little genius in chemistry, by the way, one of these genius chemists is at IU, who really help devise or develop some of these new drugs.
Hmm,
Um, the GLP-1s have been alone or in combination with other types of very similar hormones or proteins,
mhm.
um, are used now, and what are used, clinically. Obviously, they've been approved by the FDA for to treat obesity and to treat diabetes. And what they have remarkable effects. Okay, they can lower blood sugar, they can help control diabetes, they can lose weight, as you know, a lot of weight. And by the way,
Right.
there are a number of drugs, similar related drugs that are coming down the pike that you're going to lose even more weight. They lower blood pressure, they lower insulin levels, they can also treat a number of other diseases.
Wait, they lower insulin levels or they lower blood sugar levels?
They lower blood sugar levels, and I
Okay,
believe insulin levels as well, okay,
okay.
like fasting insulin levels. They they can also treat a variety of diseases now that are also scourges, like fatty liver disease, which can turn into cirrhosis,
Mhm.
which is now the number one cause of cirrhosis. They can treat sleep apnea, um, cardiovascular. I mean, these drugs now have been shown to lower the risk of heart-related death, total mortality, kidney disease, or progression of kidney disease. They're extraordinary. We still don't quite understand. I mean, there's still so much to learn. We're just in the
Yeah.
infancy stage.
I've
But
even
these
heard
drugs,
about it as treating, like, compulsive disorders such as,
we've
chronic drinking or gambling, you know?
that's another area. I mean, I think we're probably going to find a lot of areas
Yeah.
where it's going to be useful.
Wow,
Now,
okay.
these drugs are not perfect because I mean, they cost a lot.
Mhm.
And though the costs have actually been, you may know, very, very recently cut
Right,
to a quarter or something like that
right,
via the Trump administration. Um, they, if you want to retain the benefits, you need to take it indefinitely, at least at this point, because if you stop them, all these good things now reverse.
right.
And they have side effects. So the side effects are not, I mean, they're not horrific, but for the most part, they're GI, stomach, nausea, vomiting, diarrhea, constipation, maybe other rare things, but for the most part, they're reasonably well tolerated. Um,
So it
And
doesn't
some people,
cause, like, muscle atrophy, like, in the heart or the brain or anything like that, that
so
people talk
yes,
about?
yeah. So I've seen muscle atrophy in the heart. I don't. I can tell you that anytime you lose weight, whether it's through diet
Mhm.
or through bariatric surgery or through the medicines, you're going to lose some muscle mass. Now, do you lose muscle mass in the heart? I'm not certain. I can't remember any study that did that,
Mhm.
like with a regular diet. But I will say I'm not that concerned if there is a sign of muscle atrophy in the heart. Why? Because people die less of heart disease with these
Right.
drugs than without them.
Well,
So,
you don't have to pump as much around this giant body, right?
oh, that's well, for whatever reasons, and there are a lot of potential beneficial reasons we can go into if you want, but it's not, that's more technical reasons. But I see tremendous benefits here. So, yes, there are concerns. Some of it is, I think, overblown or even not based on reality that we see
Mhm.
online on the internet.
Yeah, see, I had
And
no idea, and so I'm really interested to hear your take on this. That's great.
yeah, fascinating stuff. Yeah, it's really it's extraordinary. And from a standpoint of kidney disease, this has really been it's a remarkable drug because there aren't that many drugs that can prevent or slow down the progression of kidney disease. And this seems to be one of them in
Wow.
one class. Yeah.
Well, that's very interesting, and I appreciate you sharing that with me because you hear a lot about it, and it's very controversial, and people will say, "Well, people don't need them; they should just lose weight by diet." But that's easy for people to say who don't have an obesity problem.
Yes, we can actually, since we're talking about obesity, I will say always lifestyle should be the first, uh,
Attempt,
right, the first line of treatment.
right?
Um, and but the interesting thing is we still don't even truly understand why obesity develops.
Right,
I mean, we think it's because of overeating or less exercise. I'm not sure it's that simple. I mean, there may be a lot of other things. Clearly, our society is what some people call adipogenic. Like it is a very encouraging of people getting fatter. There's
mhm,
something in our environment, whether it's the food, the behavior, something we don't really know for certain.
right,
But the you know, but we know that also we know from studies that most people cannot keep weight off. I mean, they may be able to drop weight
right,
initially, but keeping it off for years, it's just very hard for most people. Now, maybe part of it is willpower, but we're living in this environment. You just can't attribute all of that, I think, to it.
right,
Plus, I see patients and many, many other doctors see patients, cardiologists, liver specialists who already have the damages of obesity. And,
right,
these people have tried to lose weight for 5, 10, 20
and
years. I
they're
mean,
suffering,
and they're suffering. And what am I going to do? Wait another 10 years? Nothing is ever going to happen. You have to treat them. You have to try
right,
to protect them, improve protect them from all these diseases.
mhm,
So, yes, lifestyle is absolutely critical, but I think this also plays an important niche in thing. It plays an important role. There's a
mhm,
real niche for it, a major niche for
mhm.
these type of drugs.
That's very exciting. I appreciate it.
Yeah,
I'm trying to think if there's anything else I wanted to ask you. You are a wealth of information and delightful to talk to, so thank
thank
you.
you.
Um,
Speak to my wife about that, but yes, yeah, wealth of
well,
information. Yes,
all wives have different
but
perspectives.
yes, they do. No, she's very tolerant of my chatting away about these things.
Well, that's very nice. I always like to ask my guests in this environment of chaos, because I believe we do live in a very chaotic environment now, more so than even 5, 10 years ago, because of all the media coming at us, because of how incredibly divided we all are, and how easily people are incited to anger and hatred. Um, how do you keep a peaceful life, live a good and useful and productive life? Do you have any tips or tricks?
Tips
Um,
and tricks.
tips or
Well, I mean,
tricks?
what I'm going to say is not anything new. It's not that I thought of this. Look, family,
Hmm.
religion from a standpoint, and um, just I think focusing on those things are very important. Having an idea that you know there's a higher power, and each individual has their individual talents, and try to achieve those goals to make the world a better place. I don't know. I mean, whatever. I'm not. I suppose those are some thoughts that I have on that matter. But
Mhm.
I'm sure there are many other things. I do exercise. I try to. That's the way I release all my stress and tension.
Mhm.
Um, yeah, that's I think, and yeah, I think that's sort of some thoughts there
Well, it's good
on
stuff. I
that
mean,
little
it's
question.
I think it's in real life stuff that keeps us sane. So,
Yes, I think so. We need sanity
yes.
today. That's for sure.
Yes. Well,
More
you
sanity.
have sanity, and thanks for sharing yours with me.
I
And
appreciate it.
I hope you'll come back on and talk to me again.
Thank you, Joni. I really enjoyed it, and I
Yeah, I did
really
too.
it was a pleasure for me to speak to you. And hopefully, we'll have the opportunity, as you said, to chat more about some of these things.
Terrific. Thank you, Dr.
Okay.
Friedman.
Okay. Take care. Have a great evening.